Mike Caljo has a beard. Wow. Good morning, everyone. Welcome. Good afternoon. Yes, good afternoon. Welcome, everyone, to our first Advisory Council meeting of 2020. Thank you so much for taking the time to be here today. I know there are many demands on your time and really appreciate this opportunity to meet together and really this is a really important meeting for us at the Health Policy Commission and this particular Advisory Council meeting because it's our first one of the calendar year. We've just issued the cost trends report and it really is kind of the beginning of the new cycle for us as we think about what are our priorities and strategies going to be for this calendar year, what are some of the themes that we really want to dive deep in on, building off of the work from last year, but also kind of setting some new agendas and some new goals. So really important meeting today. So I'm so pleased to have so many people here today. In your folders, you have a couple of materials that I'll just walk through quickly. You can just see an agenda for today's meeting. Really the main bulk of today's meeting is going to be reflecting on some of the policy recommendations that we included in this year's cost trends report. And really to get your advice and counsel about how the Health Policy Commission can best advance these priorities, how we can work with you to advance these priorities, and if there are also things that we can do from a research or data perspective that would further build momentum and urgency on some of these topics, or if there are other topics that we missed. Certainly want to have this conversation about how we kind of take this, I think, pretty robust menu of ideas, 15 different recommendations, and make it into an action plan for this year. We're also going to touch on and want to brief you on our new responsibilities for reviewing drugs that are referred to us by the Office of Mass Health. This is new responsibilities that were authorized for the Health Policy Commission in last year's budget, originally proposed by Governor Baker, went through kind of the budget process. So we, I don't think have had an opportunity to really kind of dive deep on this particular topic with this advisory council, but this is a really important new area for our work and really want to be able to get, again, your advice and counsel. So what we'll probably do today is give you a little bit of just a process update of where we are to date with the kind of the regulatory process and begin a conversation about how we kind of move beyond the regulatory process into how do we actually do this work and do it in a way that is going to provide value to the Commonwealth and to patients. And so we'll kind of begin that conversation. Behind that, you can see our meeting calendar for the year. This includes all of our board and committee and advisory council meetings. So hopefully you can have an opportunity to lock in some of the advisory council dates now on your calendar. You can see we've already started to plan for the next year's cost trends hearing. So again, a whole nother robust year of meetings at the Health Policy Commission. And then behind that, we have a new sheet here. This is the 2019 to 2020 Advisory Council. This is an updated membership list. And we updated the membership list because we had a few people who have retired and moved on. And with that, had a great opportunity to bring in some new voices and perspectives onto the council for this calendar year. So I'm really pleased to announce, as Colleen already did in her email, that we have two new members to the HPC Advisory Council. Colin Killick, thank you so much, from the Disability Policy Consortium, and Bob Coughlin from Mass Bio. Bob couldn't make it here for this first meeting today, but is very excited to be a part of this council. And obviously, these are two organizations that are really focused both on kind of the innovation side of the pharmaceutical industry, but also on the patient advocacy and patient access side. And we really thought it was important to continue to bolster the perspectives and expertise on this advisory council as we dive deeper into the pharmaceutical issues. We've got some great people who have been a part of the advisory council for a long time, who come from the industry or that represent consumers health plans, providers. I think everyone at this table has an interest and a perspective on issues related to pharmaceutical pricing and value and access. But again, wanted to kind of continue to bolster the really important voices at the table. So thank you, Colin, for being here at your first meeting, and hope to see Bob here at future meetings, bringing his unique energy to this advisory council. Behind that is just an executive summary of our cost trends report. This includes kind of a slimmed down version of the policy recommendations, which we'll walk through in some detail today. But before we dive into the agenda, as always, I do want to just go around the room quickly and have everyone introduce themselves and their organizations, both for the new members that are here, but also, of course, for those who are watching from home or from their computers on our live stream. Again, green means go on the microphones. And I'm going to start off with Colleen Elstermeyer, my Deputy Executive Director.
Well, I don't think I need to introduce myself. No. Colleen Elstermeyer, HPC Deputy Executive Director. Thanks.
David Auerbach, Director of Research, HPC.
Chris Philbin, Partners Healthcare.
Colin Killick, Disability Policy Consortium. We're a statewide disability civil rights advocacy organization.
Emily Dulong from the Massachusetts Health and Hospital Association, here on behalf of Steve Walsh.
Carlene Pavlos, Executive Director of the Massachusetts Public Health Association.
Pat Kelleher, Executive Director, Home Care Alliance of Massachusetts.
Cheryl Pascucci, I'm a family nurse practitioner at Bay State Franklin, the most rural county in Massachusetts.
Monica Sani here from Mass Health.
Abby Selnicker from Third Rock Ventures.
Meg Hogan from Mass Home Care.
Bonnie Gilbert, Greater Boston Interfaith Organization.
Audrey Gasteyer, Massachusetts Health Connector.
Ron Dunlap, Massachusetts Medical Society.
Rich Buckley, AstraZeneca.
Marianne Bray from the Massachusetts Nurses Association on behalf of Julie Pinkham.
Amy Rosenthal from Healthcare for All.
Chris Gilley from the Business Roundtable representing J.D. Chesloff.
David introduced my beard, but I'm Mike Caljo from Blue Cross Blue Shield.
Chris Carlozzi, National Federation of Independent Business.
Laura Pellegrini, the Massachusetts Association of Health Plans.
Marcy Sindel, HHS Health.
John Hurst, Retailers Association of Massachusetts.
Great. Well, thank you again for being here. Before we dive into the agenda, I just wanted to share a bit of news with all of you. If I seem a bit off today, I've just come from a red-eye flight from California where I was there just for a short 24 hours testifying before an assembly committee there on healthcare. As California governor has proposed a new Office of Healthcare Affordability in their budget this year, modeled in large part after the Health Policy Commission and the work that we've done here. That would set in California for the 35 million residents there benchmarks and targets for sustainable cost growth, and really create a shop that is really focused on enhancing affordability in that state. And so was able to be out there presenting with another state representative from Oregon on the experience that we've had over the last 7 years and the successes and continued challenges that we've had. But I think just a real exciting development. As you may know, Massachusetts was the first state to establish a sustainable healthcare cost growth benchmark, an all-payer target. There are now 4 states that have such a target. So we were first, but Rhode Island, Oregon, and Delaware have all established either through legislation or through an executive order their own healthcare targets. In Oregon, they're calling it a sustainable health growth target. So they changed it from a benchmark to a target. That was part of their innovation. But in addition to California, who is, as I said, Governor Newsom has proposed an Office of Healthcare Affordability. Governor Murphy in New Jersey has also proposed an Office of Healthcare Affordability, as well as Colorado, Washington, Connecticut, and Maine are all in different parts of the process of thinking about establishing cost growth benchmarks and/or kind of offices that are really focused on healthcare costs and healthcare affordability. I think this is just a real reflection of the work that we have all collectively done over the last 7 years, and I think a reflection of where states are at. States, as we were, who had focused on healthcare access and really had it as our goal to figure out how we get everyone insured, and then had shifted the conversation to say, how do we afford this over the long term and ensure that people can actually afford the health care? Many other states are now in a similar position where they're really thinking about sustainability and sustainability in a really holistic way across the entire healthcare system. So wanted to share that good news with all of you. I will say and share with all of you that as part of whenever I talk to other states, I talk about this advisory council. I talk about how this was one of the first, if not one of the first things that I did as executive director when established, 7 years ago. I saw how important it was going to be, even beyond my board and the HPC's board, to have a place where many other important perspectives and expertise are brought into this conversation and in a continued and sustained way. So it's kind of crazy for me to think that we've been doing this for 7 years, and I look around this table and I know that there are some members here who were a part of that inaugural advisory council 7 years ago. Thank you for those members who have been here all those 7 years, coming to most of the meetings, and for all of the new members along the way. It continues to be a refreshed and renewed source of support for the collective work and shared goals that I think we all have around quality, access, and ultimately affordability for families, individuals, businesses, and taxpayers of this great Commonwealth. So thank you, and I will be sure to keep you updated as other states continue to innovate and learn from each other in some of these important areas, and as we can learn from other states as well, because this is a constant evolution. So with that, David, would you mind passing me the clicker? Great. All right. So diving into the slides, I already made this announcement, so thank you again. Big upcoming event. Wednesday, March 11th, we are going to be holding our annual hearing on the healthcare cost growth benchmark. So this is a hearing that we hold in the spring every year to solicit input and feedback from stakeholders on the board's decision to potentially modify the healthcare cost growth benchmark. As a brief reminder, under the statute, the default benchmark is 3.1%, but the board does have the ability to modify that up to any number between 3.1 and 3.6. And as part of that process for determining whether a modification is warranted, we do like to solicit input from the broader community. So similar to years past, we will have a brief presentation from HPC staff on some of the recent trends that we're noticing, as well as what the national projected trends are for the future. But then we also want to solicit input and testimony from other stakeholders. Many of you have given testimony in years past. It's very much appreciated. It's very much a signal of support for maintaining the benchmark at 3.1, or an opportunity to raise concerns about our ability to hit that in the future. We have stayed at that 3.1, that more aggressive target, in the last couple of years where we've had this flexibility. So not prejudging anything of the board's decision here, and do want to be able to get testimony. So if you are interested and can testify, or if someone from your organization would like to testify, there's some contact information here. And as another reminder, we do hold this hearing in conjunction with the Joint Committee on Healthcare Financing. So many members from the Senate and the House will be there. Many legislative staff will be there. So again, it's a kind of a unique event that we do in coordination with the legislators and the staff. And so just something else to keep in mind. Anything else on that, Colleen? Oh, yes, we also accept written testimony if you prefer to give testimony that way. Great. Okay, so quickly before we dive into the cost trends report, did want to continue to just give an update at every one of these advisory council meetings about what our docket looks like in terms of some upcoming publications. And I think it's fair to say that all of these publications we do expect to release before our next advisory council meeting. So very briefly, and I'm happy to kind of pause on this and take some questions if people have them, but we are in the final stages of finalizing our study of the impact of drug coupons on both kind of access to drugs, but also on total healthcare spending. We are continuing to do some deeper dives and work into the areas of telehealth and telemedicine. Marcy, did you want to jump in on drug coupons? Sure.
On telehealth.
Okay. Well, let me just say really quickly on telehealth. So we have a couple of things in the works on telehealth, but the one that will be most timely here, and then we may get out in the next 2 weeks here, is we did a look into the all-payer claims database to try to understand some of the trends that we can observe in the claims data about the use of telehealth. And where we're now have gotten more recent claims data where we're seeing pretty significant increases in the use of telehealth. We'll be able to provide some demographic information about who is using these types of services, as well as which health plans are kind of increasing trends in the use of telehealth, as well as provider organizations. So we're going to be able to cut it a couple of different ways in terms of really trying to understand some of the emerging trends that we're noticing in telehealth. So I'll pause there, Marcy.
Yeah, there's an important issue in telehealth that if you could look at as part of this, which is that the national providers, because of the way their contracts are written, you know, the Teledocs and American Wells and MD Live and all of those, they're able to set a single price for all consumers and not have to deal with the ramifications of a commitment to ensure that you only bill folks for what, you know, for what they're covered for. For us, if you come to us, we have to make sure we understand what rate, you know, whether you're covered for telehealth and what the allowed amount is. And today, we don't get the information at local providers, and I think I speak for all of the local providers. We don't get that information the way we do for office visits and other kinds of visits, such that you could do it at point of care. And so if you look at what local providers are doing, they're really not doing a whole lot relative to urgent care and other things. And I think it's disadvantaging the local providers at the expense of the national providers. So it's actually a pretty big issue, and I'm happy to talk to you more about it offline.
Yeah, that sounds great. Is it information that you're not getting from the health plans?
Yes.
Okay. Great. So we will definitely follow up on that. I think we're planning to have kind of a series of publications on some of our learnings from telehealth, both from some of our investment programs where we did telebehavioral health care programs. And so I think a great opportunity to continue to dive in. And obviously this is a central, one of the pieces in the governor's legislation, and a piece that has a lot of legislative support. So we want to be able to help inform that debate as it moves forward.
Yeah, I wanted to say that there's a huge pickup in telehealth in the post-acute space and home care, but because it doesn't go into the all-payer claims database because it's part of the Medicare bundle, so you don't really see the use sometimes of post-acute care, telehealth, vital signs monitoring, that type of thing, because it doesn't get submitted into a claims database.
Yep. That's a good flag, and I think that we're going to find that there's going to be a lot of that we're not going to be able to observe just by looking at the claims data, and some of that may be good to know where our blind spots are as well. Alan?
I don't know if it's reflected in the information you have access to, but I know expensive telehealth can sometimes pose communication access concerns for certain of the populations that we work with, deaf and blind people especially. And so it would be interesting to see if this expansion is, if it's being expended in a way that addresses that, or otherwise it might raise distributional concerns.
That's great, thank you. Yeah, Marcy?
Another area you may not pick up on because we, again, have reimbursement issues around it is teledermatology. And we're happy to talk with you about our program and what it costs us that's not going into claims data.
All right, well, I think this data points, I think, will be a good, probably a launching point for conversations about what we can observe, what we can't, and where those blind spots are, where those gaps may be that we want to be able to ensure that we're being able to track over time. I will say, having kind of already looked at the data, not to give away too much of the headline here, but one of the biggest areas that we did see a growth in these claims during this time period was for mental health services. So I think that's, so we'll be able to kind of look at both the services, kind of some aspects of the population. And again, this is commercially insured patients through the APCD, but look forward to further conversations on that. So quickly, some of the other, do you want to add anything on that, David? Okay. Some of the other publications really quickly, we have closed out or are about to close out our final publications for the CHART program, including a significant evaluation of the program and its impact. But we've also created a practical resource, which is really taking some of the kind of tactical learnings about how our hospitals and community hospitals and the teams at the community hospitals were successful. And we hope this can be a great resource and tool for other institutions or other providers who want to learn about what the best practices were that came out of that significant investment. We are also working on a brief on nurse practitioners and both kind of the growing role of nurse practitioners in Massachusetts, the workforce, again, kind of their role, continuing emerging role as the direct primary care provider, as well as kind of some of the billing differentials that can occur, incident to billing and how often we think that may be happening. So again, this is another aspect that has been a part of the legislative conversation is around expanding the role of nurse practitioners, and want to bring some data and evidence to bear to, again, help inform what we think is a really valuable part of our workforce that should be expanded and supported. I don't know, David, if you want to give a little bit more preview on that one.
That's most of it. We show variation in the role NPs are playing by provider organization. I'm not sure if we show it by payer, but trends from 2015 through 17 on a number of these metrics.
Great. So moving quickly through some of these other ones, we are updating a report that we did many years ago now called Community Hospitals at a Crossroads, looking at some of the market dynamics more in the hospital space between community hospitals, academic hospitals, medical centers, teaching hospitals. So we'll have some new refresh data on many of those metrics. As part of the benchmark hearing, we're also taking this opportunity to reflect on the performance improvement plan process. The PIPS process is, the key accountability tool that exists in Chapter 224 and as part of our structure. We've been through multiple cycles of receiving the confidential list from CHIA. We have not, the board has not elected to date to take the step of requiring either a health plan or a health system to implement a performance improvement plan. But nonetheless, through these years of kind of review and cycles, we do think that we've really learned a lot, and so want to both reflect some of the lessons learned and some of the challenges with that review process. And so kind of we'll have a retrospective. Obviously, this is a confidential process, so our ability to name names and be very specific is somewhat limited, but we do think that there are some aggregate things that we can say, after multiple years of going through this process, what have we learned, and are there ways we may think about improving that review and accountability process moving forward? And then finally, we have our investment program, which is focused on increasing access to behavioral health care, as well as addressing health-related social needs, our shift care program, and we're going to have profiles of every one of the investments that we're doing there and what they're aiming to do. So, just a couple of things in the next couple of weeks, but excited to continue to be able to put data, information, research, evidence, and tactical learnings out into the world. So any quick questions on upcoming things? And again, if you see something here that you're like, I really would love to get a chance to weigh in on or provide some feedback, you don't have to do it right now. Come find us after this meeting or shoot us an email, as we're still working on many of these things, and there's still an opportunity to weigh in. Cool, great. All right, so moving on to the policy recommendations in the 2019 report, and again, you can see in your the last 2 pages of the executive summary that was in your folder. These are summarized. The report itself contains more detailed versions of these recommendations. But I think for the next part of the meeting, I really just want to talk through some of our recommendations and again kind of pause along the way and get your feedback and input about how we can move these forward, things that we might want to add in terms of priorities or sub-priorities to these different policy recommendations, and again, and ask for all of you to say, how can we work together? Because many of these are not things the Health Policy Commission can do alone, but really do require collective action across market participants and policymakers. So I will say right at the beginning, there's 15 recommendations, which is a lot. I think it's our most recommendations for a cost trends report ever, but many of this is kind of the greatest hits version of our cost trends report recommendations. And so as you can see, we've kind of divided this up into some brand new recommendations as well as recommendations that have been included in past reports, but that we still believe need to be addressed in some important ways. So we'll start with the new recommendations. I'll kind of go through each slide and then kind of pause to kind of open it up for discussion. So the first slide here on slide 11, there's 3 new recommendations, and these are pretty big ones. So maybe I'll actually pause after this first one because it is a really important one. The Health Policy Commission is making a recommendation that the Commonwealth should take action to increase spending in primary and behavioral health care while still maintaining our overall healthcare cost growth benchmark. I think this is a follow-on to research and evidence that is growing that a primary care-focused healthcare system can be more efficient, can result in a more equitable distribution of resources across populations, and where other states have really started to make goals to say, not just how do we keep healthcare spending growth low, which is obviously a core part of our goal, but beneath that, are there areas where we should over time think about increasing investment in areas that provide real value? So the two go hand in hand. We don't think of this as just increasing spending. It is within the healthcare cost growth benchmark. And we had our expert speaker from Rhode Island who came and presented at the cost trends hearings talking about the Rhode Island experience, where they have been able to really make an emphasis on investing in primary care. And other states are really thinking about this aspect of primary care. I would say the new innovation here, and obviously this is aligned with and consistent with the governor's recommendation, is to also include behavioral health care and to say that behavioral health care should also be another one of the kind of core pillars that we should seek to make investments on. I think really recognizing historic underinvestments in that area, continued and significant access challenges, workforce challenges, the list goes on and on. So that's one part of it, is to think about how we can increase spending in these areas. And then a second subpart of this recommendation was really around how can we use innovations like telehealth to be able to also expand primary care and behavioral health care access and build the infrastructure that's going to allow that. We also include in this recommendation that outdated scope of practice restrictions on certain nurse practitioners and advanced clinical staff should be reconsidered so that people are truly practicing at the top of their license, as well as the incorporation of other perhaps non-clinical staff like community health workers, peer recovery coaches, and other parts of the workforce to be able to, again, expand access in these two areas. So, this was our first recommendation and a really important one for us this year. And as I said, certainly aligned with the goals of the governor's legislation, but I think there is my sense is a broad consensus that these are worthy goals worth pursuing. Of course, how exactly we do that and where those investments or increased spending should go, I think are very much open for some conversation. But I'll pause there and kind of get people's reactions to this and where the Health Policy Commission may help play a role in advancing this conversation.
I want to applaud the recommendation first and foremost. And I want to note, because when the governor's bill came out, many people had questions about what it meant and how it would be done and who would be affected, et cetera, that in addition to the point you made about underinvestment in behavioral health, and to Marie Ghanem's testimony about the improvements they've gotten in the system in terms of the overall health of the population and cost savings from their investments in primary care. There is ample evidence developed outside of our jurisdiction, however valid, that further investments in behavioral health are not only warranted because of underspending, but because those investments, if targeted properly, would improve the health of the population, would undercut overuse of emergency rooms and inpatient care, and a lot of negative social outcomes that people who are untreated or undertreated experience. There are also evidence-based models, including collaborative care for adults with multiple chronic health conditions. Long, solid evidence base, again established elsewhere, but adopted here, that could help primary care and behavioral health get to the increases together. So not only investments in specialty behavioral health care, but investments in integrated care. Thank you.
Thank you, and appreciate the support there. And certainly, there's so many evidence-based models in both primary care and behavioral health care that we can learn from, as well as, I think a lot of organizations are interested in innovating on new ideas as well. I think one of the, speaking personally for myself, I think there's a reflection here, and I think it's a reflection in the governor's bill as well, that without some prodding, some targets, some policies that we are collectively saying together, that this isn't just going to happen, that it does require some statements of value. And in some ways, I think of this as a next evolution of the healthcare cost growth benchmark, which is to say we've figured out how to do this and to track this, but now we can say, all right, how do we set sub-targets that are really about making sure that the limited resources that we are investing here are going into the places that are going to provide the most long-term value to communities and to patients and to improving the health of our residents. And that's how I think these two things can really fit together. Laura?
Thank you for your comments, because my comment was going to be, MAP is very supportive of these provisions, but as we talk to folks in the legislature, there's a lot of confusion about how this might be done, and I think there is an absolute role for the Health Policy Commission to work to help the system implement these changes if they were to pass, and so I'm glad you're thinking of it as an extension of the cost benchmark.
Yeah. Marcy?
Yeah, we agree completely. I mean, these are very admirable goals and clearly places that have been underfunded. And I think one place where the Health Policy Commission could be very helpful is in doing some scenario modeling around the differences between deploying this through the payers in a particular way versus trying to do this at a provider level. So one of the concerns we have is that if you look at large systems adding 30% to their current internal medicine spend at a time when there's a shortage at all levels of primary care professionals, whether that's physicians, nurse practitioners, case managers all the way down. How is that going to influence the market share in the Commonwealth, and what does that mean for the growth benchmark? And so doing some modeling around what does it really mean, and where is the money likely to come from, and what is this going to look like a couple of years out? You know, how do you put limits on it? Those kinds of things would be really helpful, because I think if not implemented correctly, we may find ourselves worse off, not better off.
Yeah, thank you, Marcy. And I would say we've started to think a little bit about that. And you know, interestingly, because primary care and behavioral health care is such a small proportion of the total healthcare spending dollar today, actually increasing it does not mean that everything else is cut. Actually, everything else can still grow. It just maybe doesn't grow quite as fast. And so because we're starting from such a small base, the numbers actually help work in our favor. But again, you know, what is that percentage over what period of time, and how different entities may be held accountable to that? You know, the governor's, I think, put forward a really thoughtful plan on that, that I think builds off of the structures of the Health Policy Commission and CHIA. But nonetheless, I understand, you know, let's continue to think about what might the best way be, and I think we want to be able to help the legislature as they're considering the governor's bill and their own proposals have the right data and support to be able to make those decisions. You want to follow up?
Kind of, it goes along though with one of your later recommendations, which is to look at the performance improvement plans. And today it's based on year-over-year growth as a percentage, which doesn't necessarily reflect market share shifts to higher priced entities. And so that's where I think you could have unintended consequences.
Yeah. The one note I would have here, though, is through our performance improvement plan process, and I think what is envisioned here is that when we receive a confidential referral from CHIA about an entity that has year-over-year growth that is in excess of that, that is just the beginning of the conversation. And so it's laid out in our regulation and in our statute that in evaluating whether we think a performance improvement plan is warranted, some of the things that we're told to look at are, what is the market share of that organization? What is their price level? What is their patient population mix? There's a whole laundry list of different factors that we look at when thinking about whether an accountability measure is actually warranted. So it's not just a bright line. If you're above that threshold, you automatically get a performance improvement plan. And so what might the factors be here that we would want to take into consideration? Maybe historical investments in these areas would be, you know, seen as a credit. And so, you know, or market share shifts. But I think that's something that we could kind of continue to think about and noodle about is, you know, if there is an accountability mechanism, how would you want to make sure that that accountability mechanism is going to lead to the market behavior that you're trying to achieve? And I think that's the ultimate goal. Colin?
Yeah. Thank you so much. I wanted, first of all, to echo Dr. Mosh's comments and to add a couple other pieces around behavioral health in particular. I think I'm really glad to hear this proposal for greater investment. I think it's really necessary. We're seeing a lot on the ground. Firstly, just a tremendous amount of difficulty in people finding therapists who are both taking new patients and covered by their own plans. I frankly had a lot of difficulty with that myself. And also, I think particularly for people who are medically complex, who have both complex physical and behavioral health diagnoses, there's a critical shortage of providers who are capable of dealing with those simultaneously, which can lead to some really adverse outcomes. And lastly, you mentioned peer services. I think greater investment in peer services is a tremendous idea that could be tremendously beneficial in this area. They produce great outcomes for a lot of people, and they're at pretty low cost. In particular, I would urge you to look at the expansion of peer respite services and other peer alternatives to inpatient psychiatric hospitalization, which for certain folks work incredibly well and produce strong outcomes in the long run.
Thank you, Colin. And we will look into that. And I think both your comments and your comments, Marcy, speak to the intersection here between investments and workforce and how the two can work together. I think the goal is to hopefully create a virtuous cycle where we're emphasizing and investing in and creating value in primary care and behavioral health care, and that feeds into building and developing and sustaining the workforce. But how those two things like totally sync up and line up, I think we can be thoughtful about making sure that that workforce is there. But hopefully the goal is that over a long period of time, we're really kind of creating an emphasis on the places where we want to build that workforce and have the money there to do it. So again, I think the intersection between workforce needs and investment, I think, is a big part of this conversation moving forward. Ron?
One of the things I'd like to take particular interest to is the disparities across income levels. So when you look at mental health, for instance, the type of provider you get is really dependent upon how much money you make. And there are certain communities where there's no access to a psychiatrist, perhaps only in a large clinic. Given that the dual eligibles are really responsible for high medical costs and high mental costs, where this is deployed and the access for lower income people to this could have a huge impact on whether you can save money and improve care. In 2014, we had a year where more people in Massachusetts saw a primary care provider than ever before. But Alice Coombs and I did a study looking to see where the 15 most underserved communities were. And through an analysis of numerous databases, we were able to identify those areas. And even though the physician supply was adequate, the access to care for those people was worse where the demand was the highest. And it's because of the financial viability of practices. Once you have 50 or 60% of your practice be Medicaid, you better be an FQHC or you're not going to be in business.
I think it's a really important point here, and part of one of the words we use in kind of our recommendation here is a more equitable distribution of resources, and I think that kind of speaks to that core concept that is a part of this goal. It's not primary care and behavioral health care for some, but really around kind of filling in some of those gaps. But I think it's really important. I think there's some data that maybe we can bring to bear to that issue as well, and we'll take a look at that study.
I mentioned on the NP brief, we will also show that nurse practitioners are more likely to be someone's primary care provider in rural areas, in low-income areas, and also if you're on Mass Health. So that's another finding that will be on this theme.
Yeah, I was also, we're obviously very supportive of this. The governor's bill did put the 30% marker out there, and I'm just curious. You talked about increase, but I didn't know if there was an intention to put a more tangible definition to that.
I think at this point we were being respectful of the legislative process and understanding that this is something kind of under active negotiation. And so I think wanted to signal strong support for the themes, goals, and values, while I think still allowing for continued conversation about the specifics of how much, how quickly, and how the accountability intersects with it.
So I don't know if it was Marcy, or I think it might have been Marcy, who raised the point that I think that there is confusion even around that 30% number. And I think your point that because the initial investments are so low, when you talk about a 30% increase, it's still relatively it's a manageable number. I think education on that, we've been doing a lot of education on that, but I think it would be helpful for others to be doing that as well.
Yeah, and that maybe speaks to kind of some of the scenario modeling that was talked about earlier. Mike? And then I'll come back to you, Don.
Thank you guys for your leadership on this, and I think it's a well-drafted recommendation. And I know we have others to talk about, so I'll be brief. I do want to reference the work that CHIA is doing as an important foundation for the next step of your work, and CHIA is essentially creating the numerator and denominator for what the current levels of spending are. And if folks aren't engaged in that process, I think it would benefit from multiple stakeholder participation in that regard, because that will then probably provide one of the frameworks for the next level of conversation, even on the percentage of increase or the percentage of investments that we want to take on. Because if we're working from a set of foundational data that is an agreed set of foundational data, I feel like then we can advance the conversation correctly for the next step.
Yeah, that's an important point. I think again, kind of reflecting on our benchmark process, how important it was to kind of build the trust in the data in order to then be able to say, okay, well, then having, crossed that chasm, what do we do next? Donna, did you want to?
Yeah, I just want to briefly underscore the point that's been made. The initial estimates of the current spending on behavioral health and primary care combined are between 11% and 14% of total medical expenditure. So if one were to increase by 3% over 3 years, 30% over 3 years, 30% of 11 is about barely a percent, just over a percent, and and it's under 1.5% if the base is really 14%. So you've got a cap you're talking about of 3+% a year, unless, of course, the commission decides in its wisdom to lower that. But doubtful it's going to be lowered to 1. So I just want to make sure people understand those numbers and that, this is a completely feasible, achievable thing without hurting anyone else, and really warranted by the need. So I'll stop there. Thank you.
Thank you, Donna. So, Chris, did you want?
Yeah, I just wanted to say, I know it's in this first recommendation, it's sprinkled through a number of the others too, the reference to telehealth and investments in telehealth. And I just wonder if the commission gave any thought to actually having it be its own, does it merit its own recommendation, investments in telemedicine? Because where we rank compared to the rest of the country in telemedicine is an embarrassment, frankly, for the entire state. I mean, for a state that can rightfully claim to be the national leader in coverage and cost containment, where we rank in telemedicine is an abomination, actually. So I didn't know if that was something the commission staff had considered.
Yeah, I think the common phrase now is that we invented telehealth and telemedicine in Massachusetts, but we're one of the few states that hasn't taken some policy steps to advance coverage. I would say, don't read into it being less of an emphasis or an importance just because it's part of another recommendation. I think my memory now is, I think in the 2005 cost trends report, we actually talked about it, had it as its own recommendation and said we should be a national leader in a 21st century leader in this area. So I think the emphasis is important, and it is sprinkled throughout. And as I said, we're going to have a couple of other publications coming out this year that are really going to continue to build the evidence base and information about how this is being deployed and the value and benefits that it can provide. And we've had, again, just investment programs that we did with telebehavioral health showed some really, really promising results. Anything else on the primary care and behavioral health care? Ron?
Is any part of this looking at trying to increase the workforce itself?
So, we do talk in the recommendation around kind of the need to build out the primary care workforce, think about using, as we've said before, nurse practitioners, as well as other clinical and non-clinical staff to help build multidisciplinary teams. I would say, the specifics of how exactly one goes about doing that are not contemplated here. But if there are ideas that people have, I think this is a ripe opportunity to have this conversation. If we're, as I said before, this intersection between saying we want to, kind of make investments and create a value here, are there other complementary policies and actions and programs that we want to be able to pursue? So, open to suggestions.
Well, we have, our educational resources are off the chart. And if there was a way to really cut the high cost of education across these different disciplines, you could therefore increase your supply. But this is a state where we train more residents than any other state, but we used to keep 70%, we keep, I think, 28 or 29%. So we're sending doctors and nurse practitioners and everybody else to the rest of the country. So looking at how we could help finance those individuals would possibly increase our supply.
Marcy, do you want to add on something on that?
Yeah, so one of the ways that has been very effective for extending primary care has been the use of non-licensed trained, care facilitators, as well as clinical pharmacists and many other folks whose time doesn't get billed in claims. And so we're really underrepresenting both the the base and the possibility, as well as probably not capturing them in the year-over-year cost trends. And so we're hopeful that that's one of the roles that the Health Policy Commission will play, is in trying to establish some sort of base for capturing non-claims-based costs associated with primary care in the medical home.
That's great, thank you. All right, so that was a big important recommendation, so I think it was worth the time to kind of go through that. So the next recommendation is really reflecting some of the work that we have done in this cost trends report around the continued shift that we're seeing in care out of the hospital, the inpatient setting, and into outpatient and ambulatory settings. We have seen this trend over a number of years, driven by, I think, many different dynamics, including new technology and innovation, as well as investments by provider systems in building out outpatient and ambulatory services. And as this becomes an even bigger part of our healthcare system, and in some ways is now even bigger than the inpatient part of our healthcare system, we wanted to say that it's important that we examine how this market is evolving and have some greater understanding of the trends and what those impacts and trends in kind of the market dynamics, continued expansions of outpatient and ambulatory care will have on cost, quality, and access for different populations and geographies across the Commonwealth. We know that this is a point of priority for many health systems, but where we've, I think, often had a much greater insight into the inpatient side. How do we kind of continue to build our tools and examinations in the outpatient and ambulatory settings, which are, again, becoming ever more increasingly important to our healthcare system. So much more in the report if you're interested in some of these shifting dynamics, but thought this was an important area that we want to continue to follow up on and track as this continues to grow. The last recommendation on this slide is around coding intensity. Again, this is really building off of work that we have done in the cost trends report, documenting increases in coding, clinical documentation over the last couple of years that has had an impact on spending, as well as our ability to make comparable performance measurement across providers and health systems and health plans. And so wanted to continue to have a recommendation here that, again, for kind of a greater understanding of how these what is driving these dynamics, what are the potential benefits from greater clinical documentation, as well as what are some of the potential unintended consequences that we're seeing. And as this is, again, becoming an area for cost growth in the Commonwealth, really important that our resources are matched to patient needs and to where the sickest patients are, and how best can we ensure that that is actually what's happening, and as there continues to be a greater emphasis, not only in Massachusetts but across the country, on coding documentation and clinical documentation. Great. So on the next slide here, so some of these are a little bit of repeats. So on the area of pharmaceutical spending, this is not totally inconsistent with past recommendations. Continue to believe this is an area of worthy scrutiny, as well as bringing this particular part of the healthcare dollar kind of within the fold of transparency and accountability that we hold the health plans and providers to as part of our efforts around the benchmark. And this is not just about the manufacturers, this is really about having some greater transparency across the entire supply chain, from the PBMs to the wholesalers, even to the retail pharmacists, to understand how the dollars and funds are flowing through all these different parts of the puzzle, and really to have a greater understanding of what the value is for all of those different pieces, and how they may be contributing to what we know are real affordability challenges for many when it comes to drugs. We have, I think a recent study was, 1 in 4 residents are struggling with the affordability of their prescription drugs, not getting their drugs filled, cutting pills, sharing pills with family members. I think we all have heard these stories. I'm looking at you, Amy, because I think you were on our pharma panel at least. I don't know if it was last year or a few years ago, but have always kind of brought the human and patient perspective to this as well. So continue to think this should be a top priority for the Commonwealth to continue to examine these trends. And also there may be areas where payers, pharmaceutical manufacturers can work on value-based contracting and other types of innovations that may be able to better improve access to the innovations that we know are in the pipeline, innovations that I think all expect will have tremendous benefits in terms of life improvement, but will undoubtedly have a high cost attached to them. Amy?
Yeah, I just, thank you for this, and obviously we are very supportive. I think in your language that you're using right now, you did talk about both transparency and accountability, and I think that that's language that's used when we're talking about other industries, whether it's hospitals or insurers, and I just would note that in the recommendation, it talks about transparency, but without the accountability piece, you kind of need both, and so I would just point that out for future.
I think if you in the full one, I think you'll see it a little bit more. The concepts of expanding the HPC's review of drugs beyond just the mass health review process.
Yes.
So
I think when talking to legislative leaders, both terms become particularly important for them. So I'll just say that.
Great.
I think, David, thank you. I think reasonable and, as always, ready to roll up our sleeves and be constructive. I think the second half of it to me is like a forensic review of value and cost and outcomes and access. My annual comment about the top half is you may spend more on pharmaceuticals and actually get better outcomes and save more money elsewhere, and you may not. And if you spend more on pharmaceuticals and don't get better outcomes, then that's a bad policy outcome. So the notion of just reducing pharmaceutical spending in the absence of understanding what the other outcomes may be may not actually be a good health policy outcome. But in any event, you get there in the second half, and if we're having a coherent, comprehensive conversation about outcomes and value, then that's good.
Yeah, and I think it's a fair point, Rich, and I do think the two go hand in hand, as with every other part of the healthcare dollar. An examination of kind of what is the benefit, what is the value, should always be a part of that conversation, and not just to say this part shouldn't grow, this part. So I think that's, if not explicit, implicit. Alan?
That's surprising I have thoughts on this. I think this is great. I echo Amy's comment. I think you do definitely need accountability in the system. I think that it's critical. I think this group could play a key role in determining what do we mean when we say value, right? What is the approach to determining what value is? Who is involved in determining that? And how does it take into account impacts on patients and how we define quality of life? I would be curious about the risk-based contracts and value-based benchmarks piece. Could you maybe elaborate a bit more on what that would entail?
So I think this is a reflection of some of the innovations that we've observed in between manufacturers and health plans, where they have been able to negotiate kind of outcome-based contracts that say if the drug works for this patient population, the price is X. If it doesn't work, then the price is Y. I think those are not the single answer, and they do not work for all different types of drugs and diseases. But it's really more of a kind of a contracting relationship between the payer and the manufacturer to try to say, let's match up if we're getting the outcomes that we need with the dollars, and if we're not getting those outcomes, then we shouldn't have to pay for it. Rich, I don't know if you want to.
You got it. That's okay. Thank you. I think just to follow up quickly. that makes a lot of sense. I think the thing we're concerned about is the decisions, the proposal been put forward by some PBMs, for instance, saying, offering to plans the ability to deny payment for all drugs above a certain sort of cost per quality threshold, that sort of thing. This sort of that's the kind of contracting arrangement, sort of blunt instrument that I think might have severe unintended consequences, and I would hope can be avoided in Massachusetts.
Thank you. I don't think that was the intent there. Any other comments on pharma? Ron?
There's been a sort of national move to start to look at the relative cost of drugs in 7 top developed countries to see whether we're paying a lot more, and even within the states to look at other states that may have successfully negotiated better prices on drugs. So that to do this really requires you can't do it in a vacuum. You have to really see what is the justification for the high price that we pay.
Thanks. So the next one here is accountability under the cost growth benchmark. So this is a recommendation around our performance improvement plan process, and I think a reflection that we'll continue to build out in that kind of lessons learned document that I mentioned earlier that we hope to put out, plan to put out at the same time as the benchmark hearing. But just continue to reflect on some of the limitations that we've seen in this process over the last couple of years of cycling reviews, where the entities that are referred to us on a health status adjusted TME basis. And the entities that are referred to us are generally the primary care groups and the managing physician groups. They are not hospitals, they are not other types of healthcare providers. And I do think that there's an opportunity now, 7 years into this process, to think about, are there different types of, is more flexibility warranted with CHIA and with the Health Policy Commission to think about how we can strengthen these accountability tools and the metrics that go into them. As you can see, we're not super specific in this recommendation. I do think whatever this form this takes would require a tremendous amount of kind of community conversation about how those metrics would work and what new entities may be subject to a performance improvement plan. But nonetheless, I think we've seen some limitations of this important accountability tool over time, and I think want to really begin the conversation with the legislature and others around some adjustments to our statute that would allow for some more flexibility in this area. John?
David, when you talk about accountability, are you going to be looking at holding government and government entities accountable as well? And when I look at the 3.1% increases average, obviously, since you started, there are plenty of entities that are consistently below 3.1%. There are plenty of consumers that are constantly way above 3.1. We're seeing it again for April 1 for small businesses. And I have a very hard time of understanding how employees of small businesses are 3 times more sick or worse utilizers than the average consumer out there. So all I can figure out is whether there's government policies that are allowing for more margins off their backs, or unfair cross subsidies from one risk pool to another or within a risk pool. But this is, in my judgment, the healthcare issue of our times, and we've been kind of sweeping it under the rug for the last decade and a half, and it's time that we come to grips with this.
So thank you, John. And I do know, and I'm sure you're a big part of this merge market task force that the governor convened to try to examine some of the issues that you're reflecting. It's not necessarily reflected in this recommendation, but actually the last recommendation that we have, and it's not last because don't read into kind of the numbering here. The numbering really was kind of all the new ones first and concept that we want to continue to pursue, because we continue to see growing affordability challenges for individuals, for families, for small businesses, certain populations and employers that are bearing a disproportionate part of the healthcare costs in Massachusetts. And so and frankly, a challenge in making the connection between total healthcare expenditures and how that translates into real savings for real people and how they feel healthcare costs, which is typically through their premiums, copays, and deductibles, not necessarily through how we calculate the benchmark. I do think we can do both and think about both kind of the spending and expenditures that go into this, but we're also putting in that recommendation, I think, a strong stake in the ground to say this can't be an academic exercise. At some point, this has to translate into affordability for small businesses. I think small businesses are explicitly mentioned in that recommendation. And I would note, reflecting again on how some of the other states are really thinking about the healthcare cost growth benchmark and some of these targets. As I mentioned before, as even the names that they're using for some of these entities, the Office of Healthcare Affordability, they're really kind of making this connection to say that what is the goal here ultimately is around enhancing affordability for the people who are paying for healthcare. And so I think your comments are well taken, and I think that runs throughout all of these recommendations, and maybe and nonetheless, I think a continued and core part of our research agenda moving forward is where are those patients, those individuals, those residents that are again kind of facing disproportionate burdens. Chris?
This may be more of a question than anything, but when legislation passes or is proposed, do they ever send like any sort of impact statement to you to see how that will impact the benchmark? When something's proposed, does that ever come your way, or? And excuse my ignorance if that is the case.
So there's no formal process for that. There is a formal process, obviously, for mandated health benefits in the fully insured market that are required to go through a review process by the Center for Health Information and Analysis. But I would say, nonetheless, I think we've created, while there's not maybe that formal process, our colleagues in the legislature are very cognizant of the benchmark, cognizant of how their work feeds into that, and have asked us, and we will continue to kind of provide data to help illuminate what the impacts of those may be. But it's not kind of a statutory formal process.
Thank you.
Yeah. Ron?
One thing I would be concerned with is the complexity of making a choice. So the Japanese have 3,000 health plans. They rank in the top 10 in the world in terms of the quality of their health. But the key thing is the presentation of the benefits is standard and the benefits are standard. So, it'd be great if on page 1 or page 2, when you try to look at your policy, you see that the core things are there in each of these plans, and anything else, it's like an a la carte meal. If you want these extra things, you can pay for it. But it's extremely complicated for even medical professionals to pick out a plan. So I know that this is a complicated issue, but we have to do something to simplify that.
Yeah, and I think we had this conversation when we were talking about the administrative complexity project, which is again one of our recommendations here to continue that avenue. Are there ways to reduce unnecessary variation, confusion in the system, and kind of all of the downstream unintended consequences that those cause? So that kind of, I think of that kind of in some of the admin complexity side of our very complex United States healthcare system. Are there policies and ideas that we can do to reduce that in a way that's going to both not take away choice, but provide better options for either residents or businesses? So the last one on here, I'll kind of move through the rest of these pretty quickly, and then pause, and we'll spend the last few minutes on the drug review process. But reflecting the important role of employers as major purchasers of healthcare, we continue to think that employers can, should, and do have a role to play in helping to drive the conversation, and want to. I think I view this recommendation as just a continued encouragement for the engagement that has occurred, and really a shout out to the Massachusetts Employer Health Coalition, which is co-chaired by AIM and Mass Taxpayers Foundation, and the work that they've been doing in terms of bringing employers together to have these conversations about how they can be a proactive and part of the conversation. And so want to continue to acknowledge the important role of employers in all of this work. The next slide here talks about these are now kind of in the renewed recommendation space. So we're going to continue work on the administrative complexity. We are doing a little bit of a deep dive focus on prior authorization as one core element of administrative complexity that we think may be worth a deeper investigation into and some potential opportunities for improvement. Outpatient facility fees, out-of-network billing reforms. These are, again, things we have recommended in the past. The next page, again, these are all continued recommendations, continuing to move to value-based payment models, ensuring that we have a focus on health inequities and disparities in all of our policies, programs, investments, and goals. And that through every one of our investment programs and other innovation investments that we're really spreading those learnings and scaling them and expanding them across the Commonwealth. And then finally, we continue to have some research and work in the areas of low-value care or care that clinical experts have determined does not provide value to patients. There are ways that we can reduce the provision of this care. That's a benefit to patients. It's a benefit to the healthcare system, and payers and providers have a role in that. We continue to see price variation among our providers that has not diminished over time in the 7 years since the benchmark has been put in place. And then, as I already kind of mentioned, this core concept of through all of these things thinking about affordability. So a pretty broad and ambitious agenda, I have to say, for the year. But many of these are just important values and principles and stakes in the ground that we want to hold ourselves to and to continue to work with others to advance this year. So I know I moved through those last ones really quickly. So I'm happy to kind of, if there's people want to give a shout out or a point of emphasis on any of those, I'm happy to hear that.
So first, a shout out on recommendation number 11. Thank you for including a focus on health equity. The one request is, I think language is really important. With Amy, I'm with you on that. And the language in the description uses inequity, and the title of the recommendation is disparity, and you really mean inequity. And should be consistent in using that language. Disparities are just about differences, and inequity implies that you understand that there's injustice and system problems at the root of that, and you do know that, so we should use that language consistently.
Consider it done. Colin?
Just a couple of quick things. Really great, glad to hear a focus on prior authorization. Would love to engage with you on that. Disability has a significant impact on the disability community. Ditto, out-of-network billing is. Thank you for addressing that. One particular area to draw your attention to there is impact on people with rare diseases, where there often may be a single specialist in the entire state who knows about their condition and may not be in their network. And then, ditto, health inequity, and I would urge inclusion of people with disabilities in that health inequity category. Our community definitely faces some significant.
Thank you, Colin. Emily?
Can I just add one thing quickly?
Yeah.
I would like to echo Dr. Dunlap's comments earlier. I would love to see something stronger on workforce as a standalone recommendation. I think so many of these pieces that I see in here, leakage into ambulatory, urgent care. Urgent care entered the Massachusetts market because they were not under Chapter 224. And so I don't see them playing by any of these rules that we are. And then when we're talking about accountability under the benchmark, I think I would like to see, a conversation about bringing some of those providers that might not be abiding by the same rules that we are under the umbrella, and then having the conversation about standards for folks who are already there. I think, the urgent care market, that's a direct result of a lack of primary care, lack of access on that side, and then also seeing an opportunity to sort of pull patients that are under commercial plans out of community hospitals into these unaffiliated urgent care centers. So just wanted to make sure I made that point. Thank you.
Yeah, thank you, and I completely agree, and those themes are woven throughout, and I think the concept both on kind of some increased understanding of the ambulatory space is reflecting some of those big market trends. What is happening there? What are the patients that are being served? What are the impacts of that on existing healthcare providers, on the existing system, and just being able to greater understand that. And again, the accountability measures too are trying to think about how do we ensure that we're holding everyone to be a part of the shared goal and rowing in the same direction. So I take your point really well. Marcy?
Since you don't have a large enough agenda here,
Yeah.
I was wondering if capacity planning was anywhere in the thinking, because particularly as the site of, it's a little bit under site of care, but as site of care is changing, I think the worry will be about excess capacity, particularly in certain places around hospital care. And how do we want to tackle that, or do we want to tackle that as a state? Becomes part of the equation. Otherwise, we're going to find, again, challenges to trying to drive down the benchmark or put care in the right place. I mean, we're already so disproportionate compared to the rest of the country in terms of the kinds of things that are done in hospital. And I think a great example is the total joints. We're 10 years behind the rest of the country in not really moving quickly to get total joints into an ambulatory setting, largely because it's easier to keep the revenue in the hospital. How do we start to do some capacity planning that drives, make sure we don't end up with community hospital closures in places where we shouldn't have community hospital closures, and conversely that we start to translate some of the capacity that's not needed into things like behavioral health beds and other things that are needed in a way that makes sense.
Thank you for that comment, and I do think this new publication that's going to be coming out soon, which is kind of an update of the community hospitals at a crossroads report, I think will speak to some of those dynamics and start to kind of lay some foundational groundwork for the exact type of research and work and planning that you're talking about. So look forward to kind of engaging more on that topic. All right, so we have 9 minutes left in the meeting. As typical, thank you so much for all of the great conversation. I think we've feel that we've, had the right ideas and items here, and you've given us a few more to continue to think about. But certainly, I think we're really excited about this ambitious agenda and to be able to move forward on this with you and with the legislature and with the executive branch. So with that, with our last few minutes, I do want to turn it over to Kate, just to give you guys, I think at this point, probably just a process update on our drug review new authority. And again, I think I will just put as a point at the end of this meeting to say, we really want your input in on this as we continue to build this process moving forward. So if this is something that you are interested in, that you're willing to spend some time and work with us to do that, our doors are open. Kate's phone number is open and email is open. And so I'll kind of put the button on the conversation at the beginning of the conversation, but turn it over to Kate Scarborough-Mills, our Director of Market Oversight and Transparency, just to give a quick process update on this important new authority.
Perfect, great. Thank you very much, David. And thank you to all of you. I want to reiterate David's invitation to chat with us as we work through the rest of this process, but also want to acknowledge all of the helpful feedback we've gotten from many of you in this room, including our two newest advisory council members. I know Bob couldn't be here today, but Colin and his organization have been very helpful as part of this as well. So I just really quickly wanted to give you a quick refresher on this new authority. So as folks may recall, as part of the FY20 budget, the governor passed into law this summer a intersecting responsibility between Mass Health and the HPC around Mass Health drug pricing. So the first part of the law authorizes the Executive Office of Health and Human Services to enter into supplemental rebate agreements directly with drug manufacturers on top of the rebates already mandated by federal law. If negotiations are unsuccessful and a drug meets certain high cost thresholds of a cost of $25,000 per member per year, or $10 million in the aggregate for the Mass Health program after rebates per year, they're able to then refer that manufacturer here to the HPC for further review. So our process is really only triggered by a referral from the from Mass Health. If a manufacturer is referred, we then have the ability to collect information from the manufacturer through a standard reporting form, which we are in the process of developing, and a little more on that in just a moment, and through tailored requests for anything that we deem necessary to assess the value of the drug or identify a supplemental rebate. Based on the submission by the manufacturer and any other information we get in our process, we have the ability to determine the value of a drug and whether the pricing of a drug is potentially unreasonable or excessive relative to that value. Once we've made a determination that the pricing is potentially unreasonable or excessive, that then triggers another round of information that can be provided to us by manufacturers and by others, and then we can make a final determination on whether or not the pricing of a drug is unreasonable or excessive. We issued regulations clarifying this process. Those regulations were voted on at our February 5th board meeting. Those were edited pretty substantially, candidly, in response to feedback from many of the organizations in this room, in particular to clarify that the public has an important role throughout this process. So we added a lot on increasing the transparency of the process, making it clear that we need to take into account any information received by any interested stakeholders. We added a lot of information in response to helpful feedback from organizations about evaluating whether or not drugs are addressing unmet medical need, impacting affected subpopulations, how drugs are being administered, the clinical efficacy and the clinical effectiveness, whether or not the drug will reduce the need for other medical care or other types of care or even caregiver burden. We added some language making it clear that assessments by the HPC, determinations of value there, were really not talking about the value for any individual patient. And we added a bunch of new information around confidentiality as well. And so all of that was really intended to be pretty responsive to the feedback we have received to date. That said, the regulation is really only the first part of the process. And so really there are three major pieces of this process going forward. So the regulation, as I said, was effective or was passed by the board on February 5th. It will be effective on March 6th. That really details the process for conducting our reviews. So the categories of information that we are collecting, the factors for consideration, and it is not intended to and does not lay out in detail the framework for doing our assessments. The framework, however, is a very important piece. You see that in the far right of this slide. That's something that we anticipate working on over the coming weeks and months with all of you and with any other interested stakeholders. That really will describe how we plan to evaluate different data sources to assess value and pricing. And finally, as discussed in the middle here, you see that we are developing a standard reporting form as required by statute. That details the information we expect to collect from manufacturers. The form we are working on with manufacturers and other stakeholders now, and it is intended to be a sub-regulatory document, much like the material change notice form or the data submission manual that we put out for the Registration of Provider Organizations program that will be updated on a regular basis, published on our website, and with some advance notice to manufacturers when we are going to update that. And so that was a lot of information very, very quickly. But suffice it to say, a lot of this will be developing over the coming weeks and months, so you'll be hearing much, much more about this. And please, if you are interested in weighing in on the information that we're collecting in the form and how we conduct our reviews and the framework for evaluating value and pricing, please come talk to us.
Great. Nicely done, Kate. All right, well, we've reached our time. Thank you again. And again, please, if you're interested in attending the benchmark modification hearing, mark your calendars or providing testimony. We do seek that as well. So thank you very much, and I hope everyone has a great day. Great Ash Wednesday.